Well, I would like to welcome everyone today. My name is Trina Laube, and I'm the VP of Strategic Initiatives with the National Wellness Institute. And we've been offering our Reimagining Wellness live conversation series here for a few weeks, and are really pleased to be partnering with the Muslim Life Planning Institute's Profound Conversation series, bringing together some really dynamic speakers today to look at painting a picture of a post-pandemic world that includes vulnerable populations. So you'll see three fantastic individuals on your screen today. We are joined by Linda Howard, Dr. Sandro Galea, and Dr. Mark Pettus. So just as a brief introduction, Linda Howard is the CEO of Alternative, which is a healthcare compliance consultancy that helps build people-forward organizations and establish compliance, ethics, and quality standards for the health, fitness, and wellness industries. She serves as the Chief Compliance and Impact Officer at the Muslim Life Planning Institute, and she is also president of the National Wellness Institute Board of Directors. So she keeps herself pretty busy, as does Dr. Mark Pettus, who is a board-certified internist, nephrologist, and integrative medicine. He's the Director of Medical Education, Wellness, and Population Health at Berkshire Health Systems in Western Massachusetts, Associate Dean of Medical Education and Clinical Associate, and Professor of Medicine at the University of Massachusetts Medical School. And he also serves on the NWI Board of Directors. And last but not least, we're joined by Dr. Sandro Galea, who is a physician, epidemiologist, and author. He's also Dean and a Robert A. Knox Professor at Boston University School of Public Health. And he previously held academic and leadership positions at Columbia University, the University of Michigan, and the New York Academy of Medicine. So we know you are all extremely busy individuals. So we thank you so much for joining us for this conversation today. And I'm going to go ahead and turn this over to Linda.
Thank you, Trina. So during the conversation today, if you have some questions, there's a Q&A option. You can type your questions in that space, and we will try to get to the questions. We may take some questions throughout, but the majority of the questions we will handle at the end. And I will ask our guests to tell us a little bit about themselves, about what they do and why they do it. And I'll start with Dr. Pettus.
So as Trina had noted, Linda, I've been at Berkshire Health Systems in Western Massachusetts now for about 35 years. And my clinical background is in nephrology, kidney-related diseases. And for many years, I did what nephrologists do. I cared for people who were very sick, usually hospitalized, critical care, on dialysis, transplants. And it was about 20 years ago that I became struck by the need to be committing more of my life and development around prevention and wellness. And that was a real pivot point for me. And since that time, have been directing much of our medical educational work out here in the Berkshires. We have residency programs in internal medicine, surgery, psychiatry, dentistry, and weaving that into more community-based wellness and prevention work, which is very much central to these population health models that are happening in every community. I'm really passionate about my work. I love what I do, and I love being able to translate the science for folks in a way that can perhaps help them empower and realize possibilities. And it's an honor to be with you, Linda, on this conversation, and to be with Dr. Galea.
Thank you, Dr. Pettus. Dr. Galea.
Well, first of all, thank you for having me join. It's really a delight to be here with Dr. Pettus and with you, Linda. So I'll tell you what I do, but maybe I'll tell also a story with it. So I'm right now, I have the privilege of serving as Dean of the School of Public Health at Boston University. And for the past 20 years of my adult life, I've been a researcher and been Dean for about 6 years now. But a lot of my research has been about understanding how the world around us causes health, and about understanding how forces like racism and poverty and how we build our cities, how that causes health, and in particular, how it causes mental health and behavioral health. That's been really what's been my focus. Now, going back in time a little bit, I'm trained as a physician, like Dr. Pettus is, and my area was emergency medicine and primary care. And I was a physician for several years before transitioning to a more academic role. And the transition happened for me when I was working with the humanitarian organization Doctors Without Borders in Somalia. I was working in Somalia, and this is in the late 90s. And I was looking after a community of hundreds of thousands of people as the only doctor there. And I was doing a lot of clinical good in a very tangible way, I think. And paradoxically, that experience had the effect on me of wanting to think beyond the clinical world. And the metaphor that I use is I felt like the guy at the side of the river pulling people out of the river, and pulling one person out of the river, pulling another person out of the river, but I was never really stopping to say what or who is throwing them in the river to begin with. And I became determined to understand that, to understand what throws people in the river, who's throwing people in the river. And I realized that to do that, I had to go back to school. And so I went back and did training in public health and epidemiology, which eventually led me on my path. So I see myself in my path as having been really concerned with understanding the forces that throw people in the river, obviously so that we can keep people from being thrown in the river. And that's really, I think, has been the animating force behind my work for the past couple of decades.
Thank you. Thank you. And Dr. Pettus, I know that you also have a podcast show. You didn't mention that. And what is it? Health Edge?
I do a podcast called The Health Edge, Linda, which is really a conversation with a colleague of mine, John Bagnulo, Dr. John Bagnulo, who has a PhD in nutrition, a master's in public health. And John and I try to do a weekly recording where we translate the science and very much aligned with what Dr. Galea was saying. Really, what are the drivers of chronic complex disease? What are the drivers of behavior? And so we spend a lot of time reflecting on topics and do a pretty deep dive. And it's been a fun way for us to collaborate, to maintain our understanding of the literature and to touch others.
Okay. Well, I'm going to ask, because we have a lot of people that's on the line, and some of them may not understand what is population health. And I'll throw that out. Either one of you can answer or both of you can answer. Just give us an understanding of exactly what is population health.
I can start with that.
You start, Dr. Pettus. You start.
Population health, from my perspective, is a concept that is attempting to transform our healthcare delivery system in a way that pays more explicit attention to not just clinical outcomes, how long people live, and ideally how well people live, quality of life, but also looking at the cost of care. We know that in America, we spend far more per capita than any other country in the developed world. And yet when you look at our health outcomes, from mortality rates to the burden of chronic complex disease to infant mortality, we really do not do that well. So from the perspective of value, outcomes achieved related to the cost of that care, Americans have not realized a system that has really created a lot of value for them from the perspective of prevention and wellness. So population health is a model that attempts to align clinical services with community-based resources, sort of clinical community integration, and usually in alliance with a payer, with an insurer that is partnering with you in a way that can attempt to manage the care of a particular group of people within a demographic, and in a way that can reduce the cost of care for those individuals. And it's a model that attempts to manage more in the community, less in the hospital, less in our emergency departments. And ideally, it's a model that should be empowering people. But it's a concept, one that we're all evolving into and with. But the emphasis is very significantly skewed toward the drivers of health, and we all know ours is a system that has not been well designed to address that.
So let me take what Dr. Pettus said and sort of take it up. And I take population health from an even higher level than what Dr. Pettus said. So population health is the health of populations. It's the health of people. Now, that sounds banal. I understand that. I understand somebody says, well, why is he telling us this? But the reason I'm saying this is because when you say to yourself that your goal is to create healthier people, it informs what you do. So how do you create healthy people? You create healthy people by creating safe housing, nutritious food, livable wages, gender equity, reduced violence, clean air, drinkable water. That's how you create healthy people. So population health is an approach that says, how do we create as much health as possible for populations? And a subset of that would be narrow health equities, health inequities. And the medical care system is a part of that. So this is why I said I'm sort of taking what Dr. Pettus said and going up a notch, because I agree with everything Dr. Pettus said, but I would put that within a broader conceptual framework that ultimately we care about the health of populations. And once we understand that, we want to put in place the elements that do that. And those elements, which are housing and food and education and income and wages and safe parks, some of those, and perhaps many of those, are outside of the remit of the medical system. So I think the medical healthcare system has a real role to play there, but a lot of it is actually outside of the medical care system. And part of our job, once we understand what population health is to make sure that those who are responsible for housing realize that they are also responsible for health, that those who are responsible for transportation realize that they're responsible for health. And that is a conceptual leap beyond what most people, good people of good conscience, who really are trying to do the right thing in those sectors, recognize as also part of their job.
Now, Dr. Pettus, I know you do a lot in the wellness space as well. But before we jump into that, because I got a couple of questions on the wellness side, can we talk a little bit about what is the difference between wellness, health, and healthcare? Because people use those terms sometimes interchangeably. And just so we understand, what is the difference in those three things?
Well, I think health traditionally, and what most of us are taught in medical school, is essentially the absence of disease. Many of us are taught how to diagnose and treat diseases. And if somebody is disease-free, we have historically, in the traditional medical models, considered that to be a healthy individual. We know that health span one's quality of life, one's functional and performance capacity, one's ability to thrive in whatever community or setting that they are in, has many upstream influences, some of which Dr. Galea briefly touched on, influences that we might consider social determinants of health, good quality food, housing, transportation, literacy, social connection. And so when you begin to look at health from a broader, or wellness from a broader perspective, you really have to include really the attributes of day-to-day life, the quality of the environment that person is in, the ability of that individual to leverage whatever resources they have to choose in ways that can optimize their happiness, their health, their ability to thrive. And again, as Dr. Galea noted, these tend to be non-clinical attributes. They speak a lot about the environment of one's home, one's relationships, one's community, one's availability of quality food. So I think of wellness as a much broader context that clearly is a driver of good health, but we know that good health is so much more than absence of disease. It is really trying to create a biology, a resiliency that can allow one to realize a capacity to thrive or to manage a particular challenge that may come up in their lives in a way that will allow them to maintain a sense of control, a sense of empowerment, and self-efficacy. And so that's one way that I think of sort of wellness much more broadly than just sort of health as we have traditionally defined it in our medical models.
Now, Dr. Galea, when I listened to your last comment, you talked about just those responsible for transportation need to understand that they're responsible for health. Those responsible for housing need to understand that they're responsible for health. When we're looking at addressing issues for vulnerable populations, Is that something that we need to be looking at a policy level, at a government level, or at an individual level?
I think we need to be looking at that at all levels. I think the housing policy is health policy, and transportation policy is health policy. There's a movement which has been around in many countries. The American Public Health Association in this country has also taken it on, called Health in All Policies approach, that essentially says that when we take action on anything that builds the world around us, be it our housing, be it our food, be it our education, we need to ask, what impact is this having on our health? Now, why should we do that? We should do that because health is a universal value. I speak to audiences all over the country, and people disagree on all sorts of things. But I have yet to find someone who says to me, I would like my children to be less healthy. We all, and I'm talking about children specifically because sometimes things get otherwise complicated with adults, but everybody wants their kids to be healthy and as healthy as possible. So when I hear that, and people want all sorts of different things for their kids, but everybody wants their kids to be healthy. So that means that health is a universal value. So when something's a universal value, then it behooves us to align our world to maximize that value. So coming back to your question, Linda, I think policies should align around creating the conditions that will generate health. And I think we as individuals should act in accordance with that. Now, what can the individual do? Well, what often you'll hear from someone who thinks the way I do is the individual needs to demand this, then demand this health. And demanding this health, not only from the elected officials in public office have the capacity to change policy, but also from the private sector, because a lot of our world is shaped by the private sector, and we should invest in the private sector that will benefit our health.
Dr. Pettus, you have any thoughts around that?
I mean, I would agree that I think at every level, from policy to implementation and execution, and really on a more grassroots level, and again, as Dr. Galea alluded to, developing capacity, social capital, community capital, it's partnering in ways that traditional healthcare models have not done a very effective job of doing with community constituents that, again, become part of this holistic approach to how people engage, the relationships in their lives and in their communities. And so it's clinical community coalitions, and a lot of that is very grassroots as you attempt to leverage policy and resources. And, I think when I look at what's happening in our community, we see many people from our faith communities to our schools, certainly to our workplaces, that do, I think, begin to see themselves as stewards of community health in ways that historically, they might not have considered in quite the same ways. So all of those things are very important, and probably never more important than they are right now.
So let's talk a little bit about the COVID in the room. COVID-19. This is where we are right now. We are really dealing with all of these issues around some of the health inequities, the population health, but we're now dealing with it in the reality of COVID-19. And I know both of you are out there working, you're on the front lines. Tell me, what are you seeing around COVID-19, and what could we be doing a little bit differently if we take in consideration the predictions that we might be seeing another wave of this come the fall?
Let me perhaps start, and I would take a step back again with COVID and say, why did COVID-19 become the epidemic it has become in the United States? Mm-hmm. And I think there are two reasons for that. Number one is because we had not invested in the infrastructure, the health infrastructure, to contain an epidemic like that. We have had decades of underinvestment in the public health systems that allow the federal government to respond, to coordinate with the state governments to interact with the local government, local municipalities. For example, in Massachusetts, where I live and where Dr. Pettus lives, we have 300 something small health departments. That is not a system that's designed to deal with something like this. So reason A is that we have underinvested in health systems. Reason B is because we have underinvested in creating a healthy world. Like, our world is far more unhealthy than it should be, considering that we spend far more on healthcare than all other high-income countries. We spend 40% more than the next closest high-income country. We get far less out of it. Just to give concrete examples, our life expectancy is about 5 years less than other high-income countries. We have more people die from chronic disease, from infectious disease, than all other high-income countries. We have higher obesity rate than all other high-income countries. And these forces mean that we have a much less healthy country than we should have. Now, when something like COVID happens, then it's not about the COVID. I mean, yes, it's about COVID, but it's about the underlay that is behind COVID. That is why we are seeing the disproportionate burden that we are bearing of COVID in this country compared to other countries. That's also, by the way, why we're seeing these racial differences in what's happening with COVID, because people of color, people who have low incomes, have greater burden of disease to begin with, and they are much more likely than both to contract COVID and have serious complications from COVID. So COVID isn't creating the problem, but it is highlighting the problem. It is elevating and it's illuminating the problem. So to my mind, the lesson from COVID is, how do we understand this and now go and build a country that is not so vulnerable to COVID next time another pandemic happens? Dr. Pettus, love to hear your thoughts.
Well, I could not agree more with what you just said, Dr. Galea. That and I would reiterate that this has revealed the limited infrastructure we have from a public health perspective, and every aspect of the structure and function of our environments is one that tends to make the least healthy choice the easiest choice, the least expensive choice. And in the example of food, addictive qualities that can make it very hard for any human who is engaging regularly to distance themselves. These are the structures that guide how we choose. Again, back to what Dr. Galea was saying, the environment really plays a critical role in ultimately influencing that choice, the choice architecture, perfectly designed to produce the outcomes that we see in the US, which is one of the least healthy countries on the planet. I also totally agree that this has unveiled the extent to which those who are more vulnerable, those with a greater burden of chronic complex disease, as ethnic minorities have, as people of lower socioeconomic status have, as people who are more socially isolated have, will have an accelerated impact from something as virulent as COVID-19. We then see, in response to this pandemic, and I'm not being critical, it's just an observation, that the infrastructure that would ordinarily support these more vulnerable individuals has been disrupted profoundly. Food delivery, not quite as easy now or as effective as it was pre-COVID. Many kids who get 2 out of 3 meals a day at their local schools may not have the same capacity that they had prior to this virus. We know that the transportation, volunteer ride sharing has all but dissipated, making it very hard for people without transportation from getting from A to B. So the infrastructure, which was fragile to begin with, has been to some extent unintentionally disrupted by being shut down and being a bit more isolated. Well-intentioned as those responses have been, I think it places those at greater risk for even more concerning challenges around recovery and re-entry, if you will.
Let me just build on that for a second, because I think Dr. Pettus brought up something which I really was hoping we'd get to. So I'm very grateful to you for doing that. Linda, you asked about COVID, and I give you an answer, and as Dr. Pettus also gave you an answer about COVID and its immediate consequences and why we are vulnerable to it. But there are two stories about COVID. One is COVID itself. The other one is our response to COVID. And our response to COVID, because we were so ill prepared, our response, which has been a sort of a big mallet approach to shut down the economy, has resulted in this enormous set of economic consequences that ultimately are going to affect more people who already had low income, who are unstably housed, populations of color, people who are single parents. These are the populations who are going to be feeling these economic consequences, and the health consequences of the economic consequences are going to linger for months and years to come. So I am deeply concerned about the health consequences of our response to COVID. And as we start thinking about sort of moving past the acute pandemic phase, and Linda, you mentioned there might be a second wave. We can discuss that, and may not be. But what we do know there is an enormous spike in unemployment, a reduction in economic functioning, and that is going to have enormous consequences for next months and years. So I actually feel like the public conversation needs to shift much more dramatically to think about those consequences than we have so far. So thank you, Dr. Pettus, for introducing that.
And Dr. Pettus, because I know we have Muslim Life Planning Institute, we do a lot of work with the organ procurement community, and I know that you are a nephrologist. So have you been experiencing an impact with those that might be on dialysis or waiting for transplants, may have recently received transplants? What have you seen in terms of this period that may have impacted those patients?
That is a really good question, Linda. And while I don't practice nephrology as I once did, and I may not be quite as attuned to some of the more recent data, we know that there are far more people on waiting lists for transplants than there are available organs. That has been a reality for many, many years. And we know that many people will die waiting because of the burden of chronic complex disease and just not having enough time to ultimately procure an organ. I do think there has been some evidence, and again, I've not looked at this carefully, that organ donation, whether that be living related donation or individuals gifting an organ from someone who is clinically brain dead, has gone down some. Whether that is being influenced by some of what's going on now, there are many people now that are fearful of engaging the healthcare system. There are many people, once they engage the system, are doing so without family with them because of just how things are configured right now. And many conversations that might otherwise be happening are probably being marginalized some. But I think it can be said that the issue of organ donation continues to be a huge issue. I don't know to what extent this will aggravate some of the current challenges, but I think it'll be an interesting thing to follow.
Yeah, when we think about the vulnerable populations, that is, one of the populations where there's a lot of vulnerability around. We also have the vulnerability when we start talking, as both of you have talked about, when we talk about African Americans, other people of color, people of low income. And so I've heard that there's the plans for, okay, how do we do testing? How do we do tracing? We're working on a vaccination. These are also communities that oftentimes, as you just suggested, Dr. Pettus, may have some distrust of engaging with the healthcare system. This is a distrust that predated COVID-19.
Yes.
So how do we take in consideration some of those distrust issues when we start looking at a plan to actually put a plan in place to actually provide the healthcare services that are needed? And either one of you can jump in on this one.
Sandro, please.
Yeah, may I offer my thoughts? I think Dr. Pettus will have his. I think distrust is a really critical issue. And Dr. Pettus used the term earlier about social cohesion, which I think captures this very well. Social cohesion is a sense that we belong to the same community. And when we belong to the same community, we are much more likely to trust that others are here to help us, including others in the healthcare system. We have not given people who are in vulnerable populations reason to trust the health system, frankly, because anyone who's vulnerable knows that we do not treat health as a public good. We do not see health as something that is a right that we should all have. The system is not trying to go out of its way to help promote your health. In fact, the system creates barriers for you to access your healthcare, creates barriers for you to access the drugs you need. With that obvious personal experience that people have, why would they then trust the system? So I really take the question of trust very seriously, and I would go back to why is there the mistrust? And I think there's the mistrust because, frankly, we have not created a system that is going out of its way to help people the way it should. So to deal with that, I think we really need to take a long, hard look at our systems and say, are we building health systems that are designed to truly help people? Once we fix that, once we treat health as a public good, something that's available to everybody, something that does not have to be bought or sold, then I think we'll see trust changing. Dr. Pettus?
That's totally agree with those great comments. I think relationship capital is really the lever upon which all that we do in healthcare and all that we do in life is essential. And I am often struck at how limited relationship capital can be between a caregiver and those that they are engaged with. Some of it is, as Dr. Galea noted, a byproduct of a system that's not well designed to enhance capital. Short visits, complex agendas, lots of people, discoordination. It's a very good model to produce an output where a person is going to feel less connected and less enfranchised. So I do think that relationship capital and some of the ways that we are attempting to address that involves much more community outreach. We all know that healthy living doesn't happen in doctors' offices. It doesn't happen in hospitals. Healthy living happens in the choices we make each and every day in our lives. We have many people now as part of our collaboration that involve community health workers, that involve more community outreach, doing more house calls, meeting people where they're at, whether that's the food pantry or the local faith community or the senior center. I think we need to be doing a better job of integrating what we have to offer into the lives of those outside of clinical settings. And so we might see, for example, someone who's addicted, someone who's been in and out of the hospital 40 times in the last year, who after 20 calls from a community health worker finally engages, starts to see a relationship from someone who cares about them. And then you start to try to incrementally build on that relationship. And it takes a lot of effort, but I think the trust capital is a huge issue. And ours is an enterprise that needs to be doing a much better job of connecting with people, redesigning our models. I think one of the unintentional and maybe positive consequences of COVID has been an acceleration of our telehealth platform, for example. So telehealth is having an encounter with a healthcare professional via your smartphone or tablet. And because of the conditions of the response to COVID, we know that people just aren't going to the doctor's office or maybe the emergency department. So we're doing a lot more visits virtually. What we find is that our no-show rates for a virtual encounter is virtually zero because that individual is in their home, maybe they're in their car, but there are very few obstacles to making the connection. I think that we're seeing a bit more innovation and acceleration of our ability to connect to people, to meet them where they're at, to try to reduce or navigate some of these obstacles that Dr. Galea had alluded to in a way to try to enhance that level of engagement. But this has been evolving over generations. It's probably going to take some time to turn around, but I think that's where we need to be focusing more of our attention.
So I'll ask both of you, what is the way forward? And I know, Dr. Galea, you made reference to that perhaps we need, and correct me if I get this wrong, a Marshall Plan in place. So why don't you talk a little bit about what that is and what would that look like?
Yeah, I use the, I mean, you're right. I wrote a piece for The Hill, which it was intentionally for The Hill because it's read by politicians, calling for a new Marshall Plan for health. And I was using that to be grand, but also because I do think it's a big effort. I actually thought Dr. Pettus's last comment saying that this will take time is correct. I think a Marshall Plan for health is one that says your health and my health and our health is determined by the places we live, where we work, and where we play. It's determined by whether we have access to safe parks and recreation, where we have access to nutritious food, whether we are stably housed, whether we are part of a fair economy that can allow us to get the assets that we need to live healthy. Once you understand that, then you say health should penetrate all policies, that we should be thinking about health all the time. And we should make sure that what we do as a country is going to be promoting health. Once you say that, you also realize that you need to structure your health system to promote that, to encourage that. That means moving health system into a way where providers are rewarded for keeping people healthy. This is some of the elements of population health management that Dr. Pettus mentioned earlier, and where you have primary care providers that look after a person's whole health, after a person's wellness. All of those would be elements of a Marshall Plan for health. Unfortunately, that is far from where we are today. Unfortunately, where we are today is a system which pours enormous amounts of money into advanced medical care, advanced sick care, care that helps people once they are sick. And, you know, I ask this of audiences all the time. Would you rather live in a society, let's say, where there's a treatment for you after you get Alzheimer's? Or would you rather live in a society where you don't get Alzheimer's at all? I have yet to get somebody to raise their hand saying, no, I want to get Alzheimer's and get the drug. No, and nobody wants to get Alzheimer's to begin with. But we keep putting all our money in the sick care system rather than creating health. So a Marshall Plan for health says, let's understand where health comes from and let us take the steps necessary so that we generate health in everything we do and create systems that can help whole populations be healthy.
Dr. Pettus.
I just have to, I love that concept of the Marshall Plan. That's beautiful. And I would echo, you know, the extent to which health as a fundamental right and the warped financial incentives of our system really need to be radically revisited and revised. And there are powerful forces at play there, but I think a lot of this work ultimately has to be grassroots, and I see many communities stepping up and people looking to create, you know, different ways of connecting. But these are very challenging forces that we are up against.
Now, if you had to give some advice to we have a lot of wellness professionals, a lot of on the line. We also have clinical people that are on the line. If you had to give some advice in terms of what could they do in order to help address some of the issues that we're seeing in our healthcare system, in the health and well-being of individuals in vulnerable populations?
Well, I can take a stab at it. And I think, I don't think it's going to surprise anybody who's been listening to this. I think that the clinician needs to see the whole person in front of her. And by that, I mean, as a clinician, you are trained, in whatever space you're in as a clinician, you are trained to narrow down, and a person comes to you and she has a broken arm. And the question is, how do you fix her broken arm? But that's not really the only question. The question is, why is her arm broken? What kind of living condition is she in? Is she at risk for violence? Is she in a neighborhood that actually leaves her with no option but to do things that are dangerous? Now, once you start thinking that way, you understand that our health, my health, your health, and Dr. Pettus's health is inextricably linked from the world around us. I think the challenge for the clinician is, what can I do? What can I as one individual do? And I'm deeply sympathetic with that question, because I do think that it's hard sometimes to think of what a clinician can do. And I often come to in my head to think that two things. One is that even recognizing this and labeling it and helping the person herself recognize it to help figure out solutions that encompass her whole life is a real value. And number two, clinicians and wellness professionals are an important voice in our society. The world will listen to you, and speaking with one voice about the importance of nesting health within the world that produces it will eventually bring about change. Dr. Pettus, over to you.
Yeah, I totally agree. Thank you for that. And I do think that more and more clinicians, I've been practicing medicine now for 35 years, are confronting value conflicts in their lives, in part because they're part of a system and they can inherently experience and feel the shortcomings of that system. And many choose, as I did, to depart from that roadmap, that playbook. And one of the challenges for caregivers today, I believe, particularly in the wellness field, is one, it was David Sackett, sort of the father of evidence-based medicine, who said that within 5 years of your graduation, 50% of what you learned will be shown to be untrue. Part of the challenge is knowing what 50% that is. We are in the midst of a knowledge revolution, an explosion of knowledge, and it's very difficult to translate that knowledge into day-to-day practice and execution. But I think it for the wellness caregiver, there is a tremendous amount of research that continues to emerge that may take a little bit longer to weave its way through some of our mainstream structures, academic structures, clinical pedagogy, if you will, and not to sound too renegade, but I do think wellness practitioners that are motivated as self-learners to maybe challenge some of the conventional ways that guidelines may be informing how best to serve another is a very important attribute as one attempts to bring that knowledge into the empowerment and life of the individuals they're engaged with. An example of that, we know, for example, that carbohydrate restriction in people with cardiometabolic syndrome, they're overweight and insulin resistant, which is probably one of the major drivers of most chronic complex diseases, has evidence for nutritional approaches that may contradict current guidelines. So I think there has to be a willingness to, in a trusting partnership, to individualize an approach, to tailor an approach, to meet a person where they're at. I can't be talking about gluten if the person I'm engaged with is food insecure and reliant on their local food pantry for the food that they consume, which may have variable quality associated with it. So meeting people where they're at and empowering oneself, the typical physician may get a couple of hours of nutrition over the course of their medical training. So there has to be a commitment, I think, to self-development, professional development, individualization, and meeting people where they're at as you attempt to help somebody find even the smallest possibility that they can realize is essential. And I think that can require a lot of patience and persistence, particularly if you're trying to make a living outside of an insurance model, as many wellness professionals have to find themselves navigating toward, because it's very hard to sometimes apply this work in the context of a 10 or 15-minute visit or an insurance model that won't always reward the work or the effort or the capital that you're sharing with another individual. So those are just some thoughts off the top about wellness providers today.
Well, I know my wellness, my National Wellness Institute family, they always have a lot of questions. And we have quite a few people on the line. So Trina, do we have any questions lined up?
Yes, we do definitely have some questions coming through, so I'll try to select a few here for you. Can you speak a little bit about how individuals could actually advocate in a few different areas. So we know that there are emergency rooms that are already overcrowded on a normal day. So how can we advocate to be better prepared to handle those future surges? How can the average citizen advocate for better infection control in nursing homes? Can you speak a little bit to what the average citizen can do for advocacy and how we can support that?
Dr. Galea, do you want to start with that?
No, you start.
Yeah, so I think the more, knowledge is power. And I think the extent to which people can be more active and proactive in acquiring as much understanding as they can with respect to who they are and how they function will enable choices, whether that's a decision to go to the emergency room or not for what might otherwise be a self-limited viral upper respiratory infection. Maybe not the best analogy today, but I think the more empowered people are in terms of their understanding of how the system works, how they can engage it in a way that can serve them better than they're currently being served. And a lot of this really does come down to fundamental practices. I think when we look at hygiene, we know that these are longstanding fundamental practices of, hand washing, maybe washing vegetables before we consume them. I think this awakens us to the fact that a lot of this is blocking and tackling as it relates to infection control, common sense. But I'll also say that I think the fear factor is quite palpable now. And one of the challenges for people as they attempt to empower themselves is how do you develop some strategies that can help you maybe mitigate some of that fear in a way that can help you navigate a bit more clearly. And that's a complicated issue, but whether these are simple breath techniques, greater self-awareness of when perhaps your ability to choose is being compromised or undermined by a particular a pattern, it becomes an important part of that self-development. We all need help with that. I think it's important that people feel connected. Ours is a journey meant to be shared, and I think the extent to which people can foster connection, can better understand where in their sphere of influence they can choose more wisely, becomes paramount to how you sort of help the system and help yourself.
Thanks.
Yeah, I agree with everything Dr. Pettus said, and I like the phrase "life is a journey meant to be shared." Thank you. I would just add one thing in answer to the question of how do you advocate. Vote. I think we are within a system where voting closes the responsibility and authority loop with accountability. Voting is what means that we hold people who we trust to create the conditions that generate health accountable. So vote.
Thank you. And Christy here is also asking, as wellness practitioners, what current government policies, issues, conversations should we be paying attention to that may have actually the potential to undermine and threaten the progress and gains that are being made with population health among vulnerable populations?
Well, where to begin? I think
Right?
that's going to take hours. When the president says that to protect us from coronavirus, we are going to shut down borders, that is a statement that is based not on science. It's based purely on xenophobia and political gain. There is no evidence that shutting down our borders is going to do anything to protect anybody from coronavirus. What it will do is it will sow division, it will sow hate, and it will create fractures in our social compact. This reflects what Dr. Pettus was saying earlier, which will harm health. So I'm using that as an example. I started with that as an example because we need to look at these policies and these statements for what they are, which are ways that result in a fracturing of social compacts, a disinvestment in creating this sense of our common good, and as a result, something that harms health. So I would encourage everybody to look at policy statements and decisions through this lens and says that asks very simply, is this creating a world that's going to promote our health? Is a policy on immigration creating wealth that's going to promote our health? Is a policy on incarceration creating wealth going to promote our health? Is a policy on housing creating wealth going to promote our health? And when it does not, we should speak up and we should say, this is not what we demand, because we, the citizens, demand health. Dr. Pettus?
Yeah, I think as we all strive to become more effective stewards of our own health and the communities that we are part of, I'd like to come back to just basic instincts. You know, we're a species that has been evolving over the last, well, modern humans, couple 100,000 years. We have a lot of intelligence, a lot of innate wisdom that has guided us and the generations before us for a long, long period of time. And I think sometimes in the hubbub of political commentary, maybe media, it can become easier to lose connection with some of those deeper instinctive guides that at the end of the day can help us choose more wisely, whether it's who to engage with or whether to go out or not. For example, it's very hard for somebody may find that they have the yearning to be outdoors because really that's what they are wired to be doing, to be outside, to be in nature. So I do think this is an opportunity for us to come back to some of the basic ancestral wisdom, the compassion, the ability to begin to look inward. And, I believe all health starts with loving oneself and being compassionate with oneself and with others. And so I think we probably know a lot more than we might realize in terms of just our instinct survival and how to connect, but it's easy to lose touch with that. And so I would encourage people to be still, to take advantage of moments where they can do some of that inquiry, and to trust their instincts, particularly when they're hearing things that don't quite resonate with where their energy's at.
Trina, do you have another question?
Yeah, we have a couple of people who are mental health providers and are asking how they can support both the physicians and nurses, as well as the general population, in particular during this time.
Yes, I can take a quick stab at that. I think the coming epidemic is one of mental illness, and we know this. We know from any number of other large-scale traumatic events, and COVID is a traumatic event, that there is an increase in mental health problems, particularly mood anxiety disorders, particularly like depression and anxiety and post-traumatic stress. And there are early studies that show that this is the case in the population. So this is coming. This is, there's no mystery here. So I do think that providers need to be aware of it. And what can be done? Well, I think there's tiered approaches. Number one is talking about it, destigmatizing mental illness and saying that mental health is something that we all have and we can all be at risk of having mental health problems. Talking about it, creating the license for people to speak up if they have mental health problems. Number one. Number two is creating the opportunity for people to talk about their symptoms, because some anxiety in a time like this is reasonable. Some sadness in a time like this is reasonable. It does not mean anybody has a mental health problem. It simply means it's a normal reaction to troubling times. Number three is to make sure that one creates the opportunity for then dealing with a provider when symptoms of mental illness emerge. And by that, typically, the line that's crossed is when you cannot carry out your personal and professional responsibilities because of your mental health symptoms. That is when it becomes important to see a provider and to make sure that the people who we encounter realize when that line is crossed and when they should be talking to a provider.
I totally agree with those excellent comments. We often talk about this concept of allostatic load, this concept of how the stressors in one's environment can reach a point beyond which one's ability to adapt effectively becomes compromised, and clearly beyond the allostatic load already present, particularly in vulnerable sectors, as we've been reflecting on, when added to a traumatic event, as this clearly is, will predictably drive many of those behavioral health issues. And we all see that in our own lives and in those that we may be serving. And I love what you said, Dr. Galea, about not stigmatizing, about understanding that these can be normal feelings and experiences of any living organism in a stressful environment. And I think that perhaps more than ever, our ability to connect and our ability to create more of that relationship capital to help people feel more comfortable expressing their sadness or their anxiety is especially important right now. And the extent to which we are, again, just as an example, trying to integrate behavioral health. All of our community teams have a social worker with a community health worker with an RN, because we know that as many as 40% of the people that we may be helping with their diabetes are also depressed or dealing with generalized anxieties. So anticipating the escalation of those expressions is something that we're all trying to get out in front of, both with the personnel that we have out in the field, the ways in which we're trying to create more safe and comfortable environments for people to come forward, and then focusing a lot where we can on empowerment through mind-body skills and stress reduction, understanding that the food insecure will not easily overcome anxiety without adequate food. And so it's this holistic managing the anxiety, the depression, the PTSD, as Dr. Galea was alluding to, becomes part of a holistic context within which you are attempting to assist those individuals. But this is what it is to be human at a very challenging and interesting time. And so as we attempt to be less judgmental and more loving and compassion, and again, leveling the playing field is especially important right now.
Thank you. And I think we could probably stay on for another couple hours with all the questions that are coming in, but I'll ask one more here. As we've been seeing, the country of Cuba has been traveling around the world, helping countries in Europe and now South Africa. So why are we trying to reinvent the wheel when Cuba is actually making great strides with fighting the virus? Anybody want to take that one on?
I think there's a lot of wheel reinvention. I mean, I think many countries have done things that are emulable. You know, we as a country have had this notion of American exceptionalism that says that we shouldn't be learning from others. You know, I'm an immigrant to the country, so I came here because actually I really do love this country, and because I love it, I would like it to be better. And one of the ways we can be better is stop having the arrogance to think that we have all the answers and learn from other countries. So yeah, I think there is a lot of wheel reinvention. I think we should pause. I really appreciated how Dr. Pettus said, sometimes it's good to be still and think about it. And when you're still and think about it, we think about that others do have solutions that are perhaps better than ours. And we should adopt those, and we should use those to create the healthiest population in the world.
Thank you for saying that, Dr. Galea. I would agree that ours is an enterprise that has always sort of perceived itself in a very sort of superior way. And, you know, ego and arrogance are great obstacles to innovation and compassion. And I do think we're going to learn a lot about the many things that we could have perhaps done differently or better. We're always looking for best practices in all the work that we do and trying to reproduce them. I'm not sure how well we've done that as a nation, perhaps not too well when you look at most of our health metrics. But I think the humility factor is a very important one, and I'll stop there.
Thank you. And I think, like I said, I think we could continue this conversation, and I hope that that we do. So take the opportunity to advocate and discuss with your peers. I do want to give you all the opportunity to speak. I will say just a little bit of housekeeping quickly for those of you that do need continuing education credit. If you've attended this live webinar, you will be able to request your continuing education credit via a link that will be sent in an email tomorrow. So again, that's for the live webinar. Linda, you want to close us here?
Okay. Thank you, Trina, for helping us with the questions and some of the technical stuff. I also wanted to thank Erica Christie, who is the Muslim Life Planning Institute's engineer. So she does a lot of the work behind the scenes that makes profound conversations happen. We also have with us Kareem Ali and Samuel Sharif, who are my partners with Muslim Life Planning Institute. And as Trina mentioned, as we started, and a lot of you know me in my role as the president of the board for the National Wellness Institute. So I really, really want to thank the National Wellness Institute for co-sponsoring this event and for all the work that they did to help market it. And I see that there are tons of questions. So I wish we had more time to be able to get to some of the questions, but I will say maybe we need to continue this conversation in another episode of Profound Conversations, or Reimagining Wellness Conversations Live. So I thank all of you for joining us today. This has been a really, really great episode.
Thank you. Thank you for having us.
Very grateful.
Thank both of our speakers for being here and taking time, because I know both of you are extremely busy in this time. So special thanks to both of you.
Thank you. Thank you very much for having us.
Thank you.
Thank you.